Finding your way with ocular melanoma, join me, host Tara McCannell, as I share with you everything that I know about this rare cancer. I hope that you will get your questions answered and be empowered to live your best life with the knowledge that you have. Please visit my resource page, sayhart.com/ocular melanoma. That's SEYHART.com/ocular melanoma for more resources and support. There you will find my handbook for patients and families, past recordings of episodes of this podcast and webinar. You will find recordings of live webinars that I do every couple of months, as well as more individualized and group support programs. Today, I'd like to talk about, is my ocular melanoma related to skin melanoma? Many times, when a person says the word melanoma, they are referring to cutaneous melanoma or skin melanoma, which is the most common form of melanoma that exists. A melanoma is a cancer that comes from pigmented melanocytes. So where else in the body do melanomas form? The most common, as I said, is from the skin melanoma. The next is eye melanoma or uveal melanoma. And then there are some more rare forms of melanoma that are mucosal, which is the soft tissue lining of the inner organs of the body. And these most rare types of melanoma can be very difficult to diagnose because they don't manifest very early and they are internal and often discovered with imaging and confirmed with biopsy. So let's talk about skin melanoma and eye melanoma. What is the difference? How are they related? Are they related? The simple answer is eye melanoma and skin melanoma are not related. I like to refer to the relationship between ocular melanoma and skin melanoma as cousins. They both come from melanocytes. They both tend to be discovered in people with less pigmentation of their skin. They are more common in people who have blue or green irises. However, that is about the only way that they have commonality. Let's talk about how eye melanoma and skin melanoma are vastly different. Let's start, first of all, with the molecular aspect, down to the cellular level, down to the mutations. We have found that the mutations that we commonly see in skin melanoma are never found in eye melanoma, and vice versa. There are mutations that are very specific to eye melanoma that we do not see in skin melanoma. So in eye melanoma, in almost every ocular melanoma cancer tissue, there are mutations in GNAQ and GNA11. These are mutations in receptors that are involved in tumor development. Many times, if we're doing a molecular biopsy where we're trying to see what the cancer is made up of, we may look for GNAQ and GNA11 mutations. Not all the time, but if you're going to have a panel of different mutations, usually these are included now that we've discovered that they are present in nearly all ocular melanoma tissue. However, none of these mutations, these GNAQ and GNA11 mutations, are found in skin melanoma. In skin melanoma, it is very common to have NRAS mutations and BRAF mutations. These are specific signaling pathways that are involved in tumor development of cutaneous or skin melanoma. We do not see these mutations in uveal melanoma. And by uveal melanoma, I mean choroid, ciliary body, iris, ocular melanoma. So on a molecular level, these cancers are completely different. And sometimes if a person is discovered to have a suspicious mass, that on pathology, and pathology is taking tissue and looking at it under a microscope, it all looks like melanoma. But if we want to figure out where it came from or learn more about what the source of it is, we can look at these molecular mutations that I've mentioned. Many times, if we find a mass, the oncologist discovers something and they find NRAS and BRAF mutations, they know that this is of cutaneous melanoma origin, the most common type. So sometimes people are found to have a suspicious mass in the liver, and the biopsy on pathology comes back that it's melanoma. One can do additional molecular testing to discover genetic mutations, which will help pinpoint the origin. Is it skin melanoma? Is it eye melanoma? And why are these distinctions important? Well, the distinctions are very important when it comes down to deciding how to treat the patient. There have been great advances and successful advances in different chemotherapies and targeted drugs for patients with skin melanoma. And these rely on having these specific mutation positive confirmation that it is indeed skin melanoma. And so there are some incredible treatments for people who have skin melanoma that has metastasized. For example, our past and God rest his soul, President Jimmy Carter had an incredible result with being treated with metastatic skin melanoma with new therapies. However, these therapies don't work if the patient has ocular melanoma. We need to be looking at different categories of treatment, different drugs. And as you may know, there is an FDA-approved drug, Kimtrak, tebentafusp, that is available that is specific for people who have ocular melanoma that has metastasized. So we need to make sure we know what cancers we're talking about. Not only molecularly are they different, but they respond differently to chemotherapies and drugs. The other difference is the natural history of these cancers. Ocular melanoma, for reasons we are still unclear on, tends to nearly exclusively metastasize to the liver. This is very unique in all oncology. My colleagues who do medical oncology and are familiar with all sorts of other types of cancers do agree that this is unusual and unique, that in ocular melanoma, metastasis tends to go to the liver. This is not the case in skin melanoma. Metastasis in a person who has cutaneous melanoma can involve anywhere in the body, the central nervous system, the lungs, the liver, bones. Metastatic disease can be discovered anywhere in the body. Therefore, when people who have cutaneous melanoma are monitored, oftentimes a full body PET CT scan that can look head to toe is used for screening in people who have high risk for metastatic cutaneous melanoma. So there are differences in people who, in the pattern of metastasis. So that's another difference. And then a final difference that, as an overview, so that you can understand how these are different types of cancers, the risk factors are also somewhat different. Yes, it is true that people who have less pigmentation and people who have blue or green eyes may end up with ocular melanoma and skin melanoma more than people who have the more heavy pigmentation. But there is, in skin melanoma, there has been an association with sunburn earlier on as associated with risk of skin melanoma. However, there is no data that sun exposure has anything to do with the development of ocular melanoma. So you might have heard someone tell you, oh, you have to wear your sunglasses to prevent eye cancer. We know that there is no data behind that recommendation. So, as an aside, I don't tell my patients to wear sunglasses because it doesn't change their risk of ocular melanoma. And also, an aside, if you happen to have a suspicious freckle or nevus, there is no data that wearing sunglasses is going to prevent that from turning into a cancer. We have no way of stimulating or turning on something that's benign and making it into cancer. And we also have no way of preventing cancers and changing them by physical actions like wearing sunglasses or closing our eyes. So if you've been worried that you didn't wear sunglasses and now you have ocular melanoma, you can just toss that concern aside. It didn't matter whether you wear sunglasses or not. So sun exposure seems to be more correlated with getting skin melanoma, and there is no data that sun exposure has anything to do with ocular melanoma. So I hope this has given you an overview about how skin melanoma and eye melanoma are very different. Sometimes we see people who have a history of skin melanoma and they have been treated and the cancer is under control, and then they are discovered to have a freckle of the eye or something in the eye. By all means, get this evaluated, have someone look at it, and follow it periodically according to your ocular oncologist or retina specialist. I hope this was helpful. Thank you very much.